Okay, welcome everybody. I think we can start. Um, we are going to do similar dynamics than yesterday. We will have first a group with Joel Farombi, Katmas Eniola, Adetutu, Sunday, and Alamuki. So all the others, you will see yourselves turned into participants now, and you will be brought back. Sorry for the unintentional Nigerian load of this group. It's been completely random. It just happened by chance. And I will start with you, Joel, Joel Farombi. What an important and neglected area of research you brought to us. Since Judy is not on the floor today, um, to talk about the importance of connections between fellows research. I actually want to bring out the important work that our fellows at OAU and now also Ibadan, thanks to Cadmus, are doing in the area of aging and elderly care research. It is widely known that the African population is aging as child mortality is reduced and longevity increases. And Farombi is one of the first CARTA fellows who graduated with a research project focused on the older adults and is now developing his research leadership skills working in the same area. And how rarely do we talk about pain among the African populations and how important it is to know what the patients are going through to be well prepared to avoid things like the opioid addiction epidemic that the US is suffering nowadays. So many patients talking about excruciating pain, deep pain within the bone, or experiencing severe limitations, and of course that feared high percentage of people self-medicating. So Farombi, I would like you to highlight for us what is the profile of an adult with osteoarthritis um, with pain who does not seek health care and often self-medicates, as you've said. And with that profile, what are your recommendations to improve health-seeking behavior of those patients? Farombi, you're muted.
Thank you for the question. From the presentation, it was shown that the demographic characteristic of the participants revealed that you have a larger proportion who are female. That's the female proportion were almost 80%. And the age also showed that majority were between the 60 to 69 years of age. That is the lower older adult age group. And also because of the setting of the study, majority of them were from the dominant ethnic population in the setting, which is Yoruba race. And also, majority of these older adults were self-employed because ordinarily, most are at age 60 in Nigeria, 60 years is regarded as a retirement age. Most individuals at that age retire from active service. And because they still have a long way to go, most of them, they still want to engage themselves in one form of economic activity or the other, so they could be able to have a source of livelihood. And because of that, they were engaged in one form of self-employment or the other. And this self-employment include many job, trading, farming, and also some of them engage in personal businesses. And for this negative seeking behavior, which includes self-medication and substance abuse. One of the problems that we have in Nigeria is that there is poor drug regulation. You have the what we call you have two levels of a drug supply. You have the registered pharmacist, and you have the lower level, which we call them the patent medicine sellers. So these patent medicine sellers, they permeate every corners of the society. You could hardly walk for in 1 or 2 minutes before you see a patent medicine store where people could easily walk in. And also in Nigeria, there are many drugs that are supposed to be, they are not supposed to be sold in this patent medicine store. But because drugs are poorly regulated in Nigeria, most of the time, people get access to the drug, both the regulated drug and non-regulated drug. The people get access to them in this patent medicine store. And this give them access to both the over-the-counter and the prescribed drug. So they have access to them easily at the patent medicine store. In some other countries, without prescription, you won't have access to you won't have access to some of these drugs. But that is not the case in Nigeria. Individual could easily walk in and request for some of these drugs. So that gave them the access to it. And also, some of the patent medicine sellers, they also take the role of pharmacists by even recommending and suggesting or prescribing what they think individual with pain, irrespective of whether they understand the sources or the cause of that pain could take. And because of that, some of these people even give 2 or 3 type of analgesic at the same time, which make the individual or the older adults to be even more at risk to conditions such as gastrointestinal bleeding. And then part of the recommendation is that affordable health care should be made available to older adults. Now, one of the significant findings for health-seeking behavior is cost. And most of the time, how much individual have in his or her pocket determine where he or she will go. Some of them, because they don't have enough money in their pocket, they could easily go to the patent medicine store because they believe that the cost of registration at the hospital will be more than what they are going to spend, even at that particular patent medicine store.
Yeah,
So
I
instead of
see that.
going there,
Okay.
they
Yeah.
will do that. And also, because the healthcare setting, there is no preference, there is no preference for older adults. Most of the time when they go to the hospital, they are asked to queue together with the other population. And some of them, they have problem in standing for long period of time. So that also discourage them from going to seek appropriate health care.
Yeah, that's very interesting. Thanks a lot for those insights. And actually, you've added a few drops of information that maybe the presentation was too short to include. Now, following Farombi, we have Eniola Cadmus, the junior of the CARTA Fellows working on aging and elderly care issues, and hopefully soon to graduate when the current problems in Nigeria, Nigerian universities are sorted. Um, Now, what an important time for this topic to be brought to the front, Cadmus, when half, if not more, of the COVID-related deaths in Europe have happened in care homes for the elder. Two questions for you as well. First, what would you say that are the economic implications of aging in place, and how can this be achieved in view of the poor social economic status that characterizes our setting? And second, knowing that access to healthcare services is a major problem confronting older adults in sub-Saharan Africa, and especially those living in rural areas, of course. How could the problem be addressed for this population while aging in place?
All right. Thank you very much for those questions. The economic implications of aging in place is not as much as what you would get if the individual were to suffer health challenges and be hospitalized. Routinely, as I've already emphasized, the family in most African settings are expected to provide care. However, they are unable to provide care. While because of ongoing social changes, which I've emphasized, while aging in place is their desire, there are many situations that may warrant them not being able to do so. Now, you can age in place within your home or within the community in which you reside. So it's not so much as leaving the individual in their homes, especially if they don't have the financial capacity to modify certain aspects of the home to make it more age friendly. However, within the community can actually come together and look at ways of still providing that care within that safety net of individuals which you're familiar with. So in terms of economic costs, this might be related to the cost of trying to do some home modifications, especially if the house is maybe upstairs and you need to put in railings or ensure that it's for you remove all hazards. And but like I said, compared with the cost of hospitalization, this is not expected to be comparable. Unfortunately, and this is part of what I intend to do, there's not much data which actually quantifies the cost of provision of care within the homes versus provision of care within the hospital setting. And as we know, most care within the hospital is out of pocket, which in many instances leads to catastrophic spending. So I intend to do much more about this and actually provide quantification, so that when we're advancing policy and advising our decision makers, we'll be able to have facts that will show that, what, this is something that you should be interested to. In terms of access to healthcare as a result of the ongoing COVID pandemic, incidentally, also an honorary consultant at the first purpose-built facility for care of older persons in Nigeria, which is the Chief Tony Aneni Geriatric Center. And within this COVID era, we had to re-strategize and see how we can provide care within for the individuals within their home, within their spaces, and limit as much as possible them coming to the hospital environment. So we have a publication to that effect, and what we proposed was to teach the individuals our clients how to safely care for themselves, monitor. Most of them suffer from morbidities, chronic conditions, and most of the things we do for them, we've been able to teach them how to monitor their blood pressure and their sugars, etc. So in terms of that, what we can do is further empower the clients, the older persons themselves, as well as look to technology. You have remote consultations now, and these are things that we need to really have conversations about and make them more visible. Thank you.
Thank you. Thanks a lot. That was very interesting. Actually, something you mentioned reminded me, and I've read a question on the chat or a comment about checking what others are doing that maybe we could adopt here, we can adapt here.
Mhm.
And there was something, there was quite a lot of noise recently about home visits. So not only self-management, but training other people who are still younger, and you are also empowering them to have a job and take care of the elder, maybe checking on how they are doing, and maybe doing the shopping for them if they need to, or go for the medicines and things like that. Thank you, Carlos. That was very interesting. We are now moving to the other end of the spectrum, of the age spectrum, with the Tutu and Sunday to study sexual and reproductive health and rights of young people. At the Tutu, you bring us an issue sometimes overlooked, but that is key for effective education campaigns and public health services, which is sexual behavior and multiple sex partners. I'm going to ask you the same question I posed to Farombi at the Tutu. With all those factors that you have found to be associated with the number of social partners, can you describe the profile of the emerging adult that has and admits to having multiple sexual partners? And how does that profile relate to the prevalence of STDs and in particular AIDS? And then I want to ask you to be a bit more specific in your recommendations. It is well known that solving poverty would solve as well half of the health problems that we are having. But while we continue working on the development of countries and to end poverty, which recommendations can we make, learning from your research findings, to guide public health policies?
Marta, the tutor seems to have dropped off.
Oh.
Let me try get him.
Maybe we can try and get him later. I have seen his name, and that's why I went for him. But then we can move to Sunday at the Dini first, and his study on the contraceptive practices and sexual behavior using national survey data. And I want to emphasize how important it is that African researchers make use of the available data, even if sometimes is scarce, to analyze trends at population level and make recommendations for policy. Sunday, you presented a striking increase in risky sexual behavior by females in the period studied, and even more striking, you presented higher odds of engaging in risky sexual behaviors for younger females. The light at the end of the tunnel, I guess, was that not only economic status, but also knowledge about HIV/AIDS correlates with lower odds of engaging in these behaviors. In this case, Sunday, I'm going to ask you to dwell on the quality of the data of the national surveys that you used. Were those data sets clean and ready for you to use? And did you lose any time points or individuals sampled due to poor quality or data gaps? And then, in your opinion, how can DHS data be utilized to inform public health policy? How much information is there already collected that could help guide public health policy?
Thanks, Marta, for your question. You raised two important questions. First, on the issue of the quality of the data. Yes, in terms of quality, based on not just this publication, but even other previous endeavors that we've embarked on using the nationally representative survey data, it has really been accepted as a very high quality data. First on the surveys, and even they tend to do very well in the peer review process because of the fact that over the years, the several methodologies that have been adopted for collecting the demographic and health survey, not just in Nigeria, but across different countries in Sub-Saharan Africa and South Asia and other parts of the world. So these methodologies have gone through several modifications and have been refined. And so because of that, they've really done very well in terms of, I'm speaking generally now, so they've really done well in terms of even peer review process, as opposed to some of the endeavors that we have done at smaller level of trying to collect data, and then you send such publications out for peer review. Many of them have met with a very strong opposition in terms of the reviewers trying to raise questions around the issue of quality. I've had experience in the process of collecting data, and you have very long lists of comments on this. So, on a nutshell, in terms of the quality, the demographic and survey have gone through several modifications. That's on the first on the general comment, but specifically for the data that we analyzed, yes, we embarked on different strategies to ensure that we ensure internal consistency and having very strong quality coming out from the data that we analyzed. And to also achieve this, we did what we comparing our own descriptive findings with what is obtainable in the final report of Nigeria Demographic and Health Survey data collected in 2008, 2013, and 2018. So we did that comparison and to ensure that we analyzed high quality data. So that's briefly on in terms of quality of the data that we analyze. But for the policy, yes, the demographic and health survey, not just for Nigeria, but for different countries, have very high utility for informing and framing appropriate interventions. Like what we have found out now is prompting us to embark on further studies with respect to deepening understanding on the issues around getting qualitative investigation to see what is happening with respect to young women. Our findings have not had total departure. It's just that we established worsening SRH outcomes, particularly among the women. So that has a lot of policy implications with respect to ensuring that if policy programs will be implemented, it has to be gender specific. And so that's also prompting us to embark on new trajectory in terms of collecting qualitative data to see what are those behavioral issues, what are those contextual issues, what are those issues within the environment that predispose young women to poorer SRH outcomes compared to their male counterparts. So it has a lot of policy implications, and I just want to throw this post as I stop that I'm currently doing a study that has a very strong policy dimension, and it's not a straightforward thing. And that was the question I was going to raise for Jude yesterday. That I think CARTA also needs to begin to do more in terms of building capacity of fellows around the issue of knowledge translation, because we have a lot of interesting findings coming out, not just in this by our own study, but even from other studies. So the policy process is not so linear, it's not so straightforward, and I think more needs to be done in terms of translating many of the findings. So what I'm currently working on now to see how we can translate knowledge into informing policies and intervention to address what we find out. So I'm encouraging CARTA to also begin to look towards that direction.
Thank you, Sunday.
Thank you very much.
We actually want to work on those lines. We do, and you know, there some of the justices already have some components of engaging with policymakers, but we are reinforcing that also at the graduate level to try and give you as much support as we can provide. I see the tutu is back. I'm going to try and pose the question, one of the questions again. I will not summarize the key findings, but the tutu, I was asking you a similar question to the one I posed to Joel Farombi about with all the factors that you have found to be associated with the number of sexual partners. If you could describe what the profile of an emerging adult that has and admits to having multiple sexual partners, and then with that profile, relate that profile to the prevalence of STDs and in particular AIDS. I hope you can unmute yourself, and if your connection doesn't allow you to show the video, don't worry. You're muted.
Hello?
Yes, Tutu, please go ahead.
Hello. Oh, sorry, I did not get your questions.
I was asking
The
you
network was poor
with the.
when
I'm gonna try and post it again, but if your connection doesn't allow us, we will have to move on.
okay.
Please keep the video off so that your connection is a bit better. I was asking you to give us the profile of the emerging adult that has and admits to having multiple sexual partners, uh, relating it to those factors that you have seen associated with taking those risky behaviors, and then how that profile relates to the prevalence of STDs and in particular HIV/AIDS.
Okay. If I get you clearly, you asked the profile of emerging adults. That's number one, and how those community characteristics were related to number of sexual partners of emerging adults. Did I get you correctly?
I think the connection is not allowing you to hear my questions. Let us try later on. We're gonna move on to the next speaker, and then we will try with you again at the end if we have time. I'm sorry about that, the tutu. Now, before switching to the other group, we are going to focus on Alamuki's research on the available genomic COVID-19 genomic data, and that is what I I call a well-used lockdown, Alamuki. I'm glad to see that you have been able to apply the knowledge and the skills of that you gained in that short course that was nearly interrupted by the restrictions and which caused you to get locked out of the continent for way longer than we were able to imagine at the beginning. And it's striking that your finding of low availability of genomic data in in Egypt, where it hit first in the African continent, is similar to what happened in Europe as well, since the Italian virus was sequenced first when it reached Brazil, I think it was, if I remember correctly. I guess that shows how unprepared this pandemic caught every single continent, and how disconnected the capabilities for genomic research and clinical care have been. Now, you have shown several clades of strains across the continent. And I have to admit that I stopped following up the nitty-gritty of the COVID genomic discoveries a while ago, but I did see a report of a quick shift that occurred in Europe when a more easily transmitted mutation appeared and cases quickly shifted from the initial strain to the new strain. Increase of the new mutation. Now, many times there is a pull between in those viral sequences between transmissibility and virulence. Lucky for us, many of the mutations that allow faster transmission cannot keep high virulence, but this is not always the case. Now, what are the consequences, the implications on transmissibility and virulence of the strains that your data reveal as being the ones that are spreading across the African continent? Is the information available enough to do that analysis? And if not, what do you think that we should be doing to ensure that we can keep an eye in the important functional consequences of those genomic changes as they happen?
Thank you very much. And I thank CARTA for sending me for the training in Sweden. It was worth it. Like we know, that's why we did the work on that, to show that Africa is yet not doing enough to make the genomic research capacity to be enough to understand this transmission. And they are very, the particular mutation that is actually responsible for pathogenicity of this virus is what they are looking at. And we have seen that there are several single nucleotide polymorphisms that could have implications on the presentation of this disease in Africa. But if we don't have enough of this genomic research capacity, we don't have enough sequences to see how many of them are they the rate of the mutation, won't be able to say much about the implication of this mutation in the transmission in Africa. And because if you look at even currently right now, I know it's improving, because the last time I checked, it has improved from when the first wave started. More sequence data has been created in the public database, and we can see that there are so many single nucleotide polymorphism that is causing different in different countries, and this has implication for the presentation. And using this, we would be able to understand how the virus is actually affecting us in Africa. And what we can also do more is to increase people's capacity, both personnel and then facilities as well in Africa. We have just a few of facilities that are actually that can actually sequence data. Most often, some other places in Africa, these data are being shipped out of the country, and it takes time. And before it comes back, and then you analyze the result. And there are still some, we don't have an institution for bioinformatics that is that much in Africa. And when we have this sequence data, we need bioinformaticians that would be able to analyze and interpret the results. And improving bioinformatics research in Africa will go a long way to help health research in Africa. And this one that the world is moving into personalized medicine, it will also help in clinical research to understand different disease presentation in Africa. Thank you.
Thank you, Alamuki. That's interesting. I hope I guess the H3 Africa Consortium may be doing some of this work. I haven't followed up closely. Maybe
Yes, they are.
these people are more
Yes, they are.
aware of it.
Yes, they are. They are
And I
starting.
hope, yeah, I hope they will put that data together and available. And hopefully we will also get clinical information to start doing some association studies. Otherwise, the genomic information is not very useful if you don't have the associated um, information about the pathogen. I can't say that now. The virulence and all those things, and what happens to the people who have that particular polymorphism, the virus, the sequence with that particular polymorphism. I'm very glad to see your work presented, and I'm looking forward to seeing more genomics data coming out now related to your PhD topic. So
Thank you. Thank you.
keep up the
Thank
good
you
work.
very much.
Now
Thank
we
you
are
very
going
much.
to shift to the other group. We wish we had more time to discuss with everybody, but we are now moving on and welcoming Marceline Finda, Emmanuel Kaindoa, Anita Filbert, Felucio Balogun, and Felix Kuluza. Somehow that felt a bit easier to pronounce, but I hope I still apologize if I got anything wrong. Now we have a mosquito-heavy group this afternoon, and I have to admit that my past as a fly researcher is already excited about the prospects. To start somewhere with the first of their presentations, Linda, what do I say? What an interesting angle you have taken to study the topic of malaria control, and how important it is that we pay attention to those details. That I have been following the development of transgenic mosquitoes since its infancy, and I was really excited to hear that the first large-scale field experiments were being implemented in Brazil. And then I started hearing about Californians going out on the streets to protest because they were against transgenic mosquitoes. And I thought, maybe we have an anti-vaxxer, an anti-transgenic problem here. I hope this will not set back the development and necessary study of one of the most promising tools that we have to finish or to fight mosquito-borne diseases. It is so important to ask the stakeholders what they think, to share with them the information with total transparency, and it is key to do it early before that resistance is developed, because we all know that changing a belief is much harder than creating a new one. I find particularly striking your finding that a quarter of the community members have a positive attitude towards the use of this technology, even if they don't really know how it works. And even more striking and concerning, the skepticism of scientists. I have to admit that sometimes I have entertained the idea of what would happen if we just eliminated all the mosquitoes the way your respondents say. And I could talk about this topic for hours, but this is time for you to talk. So I want to ask you, if you have, on one hand, if you have explored that skepticism of the scientists further, or you plan to do more work on it in the future, and on the other hand, to develop a bit further how you think your findings can inform future campaigns to introduce and regulate an intervention based on this technology. How can the skepticism of scientists be addressed? How can the policy makers be helped during the process of regulating this technique? And how can the community members be involved in co-designing the strategy that will help eliminate some, if not all, the malaria-carrying mosquitoes?
Thank you very much, Martha. Those are all really good questions, and it's been equally an interesting project to be involved in, and I'm really glad that I get this has opened doors for me to do further either research or improving on those challenges that we faced. So in terms of the skepticism from scientists, for the most part, so we did research it in depth, but for this particular presentation, I only focused mainly on the feedback from the community members. But from the scientists, what we found was that they were skeptical mainly because they felt it's currently being done. It's still done in the lab stages, but it's done in Europe. There aren't really a lot of labs. Actually, in Tanzania, there is no, I think in our institutions, for example, I did speak with researchers from 2 leading research institutions in the country, and in both of them, there was no one who was well knowledgeable of this technology, who could say for sure what is being done, what mechanisms or what possible risks could be there, and how to respond to any challenges that may arise. Mainly skeptical group in that. So after we published our first paper that provided feedback from 4 different stakeholder groups that I spoke with, so we received funding from FNIH to respond to that. And what we are doing right now is we are trying to bring together not just the scientists, but also policymakers and regulators and people who deal with advocacy on communication to say, can we sit together and discuss this? What challenges I face? What would you like to know, for example, before you give an informed opinion? Because even now, even among researchers, the knowledge of this technology is still relatively low. So we wanted to start there before they can be informed, engaged fully. We need to be knowledgeable of this. So what we are responding to as a start is to improve that knowledge, and also to start responding to some of the questions that scientists or other stakeholders have. And then from there, now we can say, okay, now you can be fully participating in this, or you can make your decision or make an informed opinion. In terms of how, for example, we can start or the future different institutions can advocate for this. I think one of my really fascinating findings that I found from this was that really the knowledge improves opinion. When we did the survey with the community members, that was before they knew anything about it. We explained the technology in the very, very general terms and say, do you know this? Do you know how it works? Would you support it? So the support was low, but when we called a few representatives of the community members in focus group discussions, now in this we provided them with a presentation of the technologies, so they had some knowledge. And then we say, now that you group discussions, although it's not representative, the participants quickly, for example, use crossbreeding their own domestic animals, which could be used as analogies for the genetically modified mosquitoes. So this really provides a starting point for anyone who wants to either engage the communities or to raise awareness. You can have that as a starting point that, yes, we do modify organisms to fit for different purposes. And in terms of mosquitoes, we can modify them so that they cannot transmit malaria or they can be eliminated. So, so I think it was interesting for me that we could get that baseline information that we can start building up on. I hope I have answered your question.
Yeah, thank you, thank you. That's very interesting, and I'm not gonna take more time. I hope we will meet in another occasion, and I will keep drilling you about your research. It's very interesting to see that kind of work coming out of your institution, as we will see other fellows also working on malaria. But I think the work on making sure that people know what we are talking about before we start saying, oh, we're gonna start dumping mosquitoes, transgenic mosquitoes on people is important, so that everyone is aware and the policies are well constructed around the technique. A technology, by the way, that is so cheap that it's ridiculous that we still have insect-borne diseases. Thanks a lot, Finda. Now we are going to move to your colleague, Emmanuel. Good afternoon. I hope you're feeling a bit better now. Thanks for rushing back and joining us. When when I saw you presenting, you reminded me of the TED talk that Fredros gave some years ago, when he described the many hours that he spent out in the field catching mosquitoes, and how much can IFACARA do for malaria eradication. We have just discussed the work with Linda, and no less relevant is your study on the actual characteristics of the houses and the understanding of the risk by the people that inhabit them. Now, your conclusions reminded me of a statement that I heard quite a while ago by a journalist whose name I can't remember because I'm just simply useless trying to remember names. But she said that Europe had built its way out of malaria. And I would like to know what you think about that statement. How do you see the future of the fight against malaria if a clear problem and a proposed solution rely on the economic status of the population? We have earlier mentioned that if we were successful eradicating poverty, we would eradicate many of the health problems as well. But we have proven ourselves unable to move at the required speed in the poverty eradication angle. So what do you think are the alternatives that current technologies can support within the current economic status of the people who need them?
Thank you so much, Martha. Good afternoon. Can you hear me?
Yes, we can. But now you stopped. Maybe you can put off your camera so that the connection is a bit better.
Yes. Okay. I think now it's better.
Yeah, actually, we can hear you clearly now.
Yes. We have evidence that apart from the interventions we have in the country, like the bed nets and indoor residual spraying and the proper diagnostics, urbanization and standard of preventions against vector-borne diseases, including malaria. So when you compare the level of urbanization in most African cities and comparing with the rural situations in African continents, you obviously see the way in urban areas, vector-borne diseases burden is not quite high as comparing in rural areas. And one of the explanation could be the standard of living and including housing. So going forward with regard to malaria elimination, I think housing is one of the important aspects, because at the moment we have the evidence that significant amount of malaria transmission still occur indoor, and mainly because the nature of the houses have open eaves, open gaps, open windows, and screened doors. So all these allow mosquitoes to enter the houses and perpetuate diseases. So what I think, and with regard to other recommendations from other people, other scientists, is that we really need a simple, scalable, and affordable interventions which could be used for housing improvement. At the moment, as you mentioned, we have the poor standard of living, including low income. And in my study, it was mentioned frequently that people would like to improve their houses, but they are constrained by financial barriers. So I think we as scientists, we need to design simple, affordable, and scalable interventions to help these communities to improve their houses. But again, we have challenges like in my country with regard to policy implementations. We have the Ministry of Land and Settlement working around, we have the Ministry of Health, and we have the Ministry of Construction. All these do not have any clear integrated approach on how we could put together components from all these sectors, health and settlements, construction, to make sure that we have constructed gate and be able to construct their houses. Because at the moment, when we visit the rural areas, we found that some people even use the old nets, putting them in the windows, doors, but these are not enough. But there are some from the community members. So to purchase this ones, hello.
It seems we are losing you a bit, Emmanuel, but
Hello?
I think we got the key point. And I hope you will continue looking at those cheap and affordable technologies that people can afford
Hello?
with their current status. And I don't know, maybe 3D printing of houses, which is already happening in other places, could be considered, or prefabricated homes, things that can ensure a cheaper cost of living units, and then the conditions can be improved at a bigger scale. As you'd mentioned yesterday, I think it's very important that the research that you have, oh, sorry, I didn't realize I had put my video off to try and help Emmanuel's connectivity. Sorry about that. I was saying it is very important that the research that you have done is put in the context of the research that Marceline has done, and vice versa. I'm very happy to see young researchers like the two of you doing such important work in an environment where you can continue working and collaborating to use a multidisciplinary approach to the persistent problem of malaria transmission. Now we are going to change to another mosquito and another virus, Anita, this time to fight dengue. Your work has reminded me so much of a friend of mine who was not as fortunate as we were and had to take a job as a research assistant in an entomology study to have some income while she was doing her PhD. Um, the days that she did not have to spend identifying mosquitoes. She kept telling us, like, the vectors are here for malaria, for dengue, for all of them. We're just lucky that the circulating parasite is too low for an outbreak. I can only imagine how many mosquitoes you've identified and how important it is to have that striking evidence of the existence of a non-mosquito reservoir for the virus. And I want to ask you about that host. I want to ask you, what do you think should be done to identify that host? What can you tell us about the biology of Aedes mosquitoes that can help elucidate where is the virus hiding with the consequent risk for a future outbreak? And then about the mosquito itself, someone asked if you have any insight about the geographic overlap of the factors that facilitate mosquito breeding, the density of mosquitoes, and the incidence of the disease. I hope you can unmute yourself. If you feel that your connectivity is not strong enough, you don't need to put the camera on.
Thank you, Martha. I'm grateful for the opportunity to be part of this conference. I will start with the ecology of the mosquito. This is an urban species that breeds predominantly in urban areas. It's a container breeder. So in most of slums,
We seem to be having a problem with the connectivity for those speaking from Tanzania. Anita, maybe you can check, you can put off your camera to see if it works better. I'll put off mine as well to see if you can hold on. Otherwise, we will have to move ahead and then come back to you because we are already behind in time. Okay, I think we have lost Anita. It was really interesting to see such an interdisciplinary group of researchers tackling insect-borne diseases coming out of CARTA. You are just the best example of one of the few. Oh, Anita, you're back. You're muted now. It seems the unmute button is not working from this side. There you are.
okay, thank you. So after this study, we are interested to find out what are the reservoir hosts, where do the mosquitoes pick the virus from. I was once moving around the campus and I found mosquitoes feeding on frogs. So we got a small funding and we want to do a blood analysis study to see what are the sources of blood for mosquitoes. And this will give us an indication.
It seems the connection today from Tanzania is not stable enough, but I think we got quite an interesting bit of information there. I hope Anita will be able to continue that research and identify that host. We are going to move to the next two presenters because we are already behind schedule, and it's already going to be difficult to interact, to give more space to the questions of the audience, even though we have tried to put them in as we were speaking. So now we are going to move to two very different topics to what we have seen. More evidence on how diverse CARTA fellows are and the different areas of expertise that are coming up of our research capacity strengthening program. First, Folusho Balagun, studying immunization timeliness and completion in children from slums, and going all the way to testing an intervention to improve the health outcomes. How important, Folusho, that you not only evaluated the training, which is where many interventions stop, but you went all the way to measure the effect at the point of at the level of health outcome, which is in this case the immunization timeliness and completion rates. You had very striking differences between the control and the intervention groups, and what a direct way to express your findings. Training older women caregivers improves infant immunization in slums. And I would follow with since infant immunization saves lives, training older women caregivers saves lives. Now, in my experience with immunization timeliness and completion, in hard to reach areas, the outcome greatly depends on access to services and availability of vaccines at the service center that is accessible. So first, a small detail that you maybe caught from your presentation related to the older women who were trained. I think I have seen an answer to a similar question on the chat. You said that the women were not related to the mothers, but you said that the mothers were bringing those older women with them. So was the selection criteria just that the women had to select an older woman to come with them? And that's how you selected the participants in your study? And then I want to ask you to contextualize further your findings within your area of study. How much of the existing immunization gap in the area could be solved by training older women caregivers, and how do all the variables like distance to the healthcare facility interact with your study? And the last but not least, do you have any plans to engage policymakers to scale up the study and test the potential of your training interventions to save lives?
Thank you, Martha. For this study, it's a build-up on an already existing tradition. In Nigeria and many developing countries, older women usually supervise mothers when they have a new infant. And this is something that has existed for a long time. But because there are so many efforts to improve immunization, and so many times these women are either ignored, even when they come to hospital setting, nobody asks them questions. And these women spend quality time with the children. Some of them even know more about the infant than the mothers, but they are usually ignored. And whatever you say in the healthcare setting, usually when these mothers get home, these older women call the shots. So in this, because it's urban slum, some of the families are not like the typical family that you see, they're like disrupted. So we envisage that the older women may not be blood relations. So what we did was we went to the antenatal care settings, both in the primary health care centers and traditional birth attendants, because some of them, that's where they do their antenatal care. And Ibadan has a good structure in a way that most of the community birth attendants are actually affiliated with primary health care centers. So they are supervised by medical officers in those primary health care centers, the activities. And so when they conduct antenatal clinic in their place, and if a woman needs to be referred, they refer them to primary health care center. Also, when the infants are born, the mothers are referred to the primary health care centers for immunization. So it's like there's a good linkage between the community birth attendants and the primary health care centers. So the women, we approached them their third trimester, and we requested that they should bring to the clinic the women who will supervise the care of their infants after delivery. So the women actually brought them. Quite a number of the older women were mother-in-laws or the mother of the grandmother. And then there were some that were neighbors, some were just friends to the mother. But these were the people that the pregnant women identified as people who would take care of their infants after delivery. And then the existing gap that you talked about, distance, the urban slum communities, because they're in the urban area, they don't have any difficulty with access to primary health care centers for vaccination. And like I said, even community birth attendants, they are affiliated with primary healthcare centers. So access is not a problem in this particular setting. And also availability of vaccine is not, is like at par with what obtains in other parts of the urban area, because they all get their stock of vaccine from the same source. So access was not a problem in this situation, and also availability of vaccine was not a problem. And about scaling up and influencing policy, there are plans already underway, because before we started, we had contact with the Commissioner for Health in Oyo State, where the Ibadan is. He is aware of about everything that went on with the study, and is also the primary healthcare the medical officer in charge of the primary healthcare centers in Ibadan is also aware. So now we have packaged the results of this study, and we are to meet them before the year ends with the results to see what can be done to improve infant immunization in Oyo State. Thank you.
Thank you. Thank you. Thanks a lot for that, Felucio. We're going to move quickly to the last speaker, Felix Kuluza. And I'm just going to try and select one of the questions that was posed to give you a chance to discuss a bit further the implications of your studies. So you were testing different protocols, and I've seen some reference to a similar report that has come out of the US recently, and you should check the chat. I think it was on the chat where that information was shared. I hope I understood you well when you were talking the TLC or the mini lab. You seem to be talking indistinctively, using the two names indistinctively for the same technique, and it seems to be the one that identifies the most samples, although it seems to be taking longer to perform. Now, if I know you've presented preliminary results, but let's think that if you were to show that one of these techniques is the one that is more cost effective, and the investment should be made to prepare people to do this kind of analysis, what is it that would take to build capacity on ground for the laboratory technicians to be able to perform these tests? How much equipment is necessary to do this, and how can it be facilitated? And then I would like you to comment on how your postdoc research grant helped in increasing your capacity to do this kind of research, and the capacity of your group to continue doing research on this area.
Okay, thank you for those questions. I would start with the TLC mini lab. It's the same thing. If I have understood properly, it's about the time and the equipment. Maybe may repeat on the TLC mini lab one before I comment that out.
Yeah, I was asking you if this is the one that seems to be able to identify a wider range of samples, if I've read your graph correctly. What would it take to train people to do this kind of tests, to perform this kind of tests on ground? What would it be required to build the capacity of laboratory technicians? And is the equipment expensive? In the end, is this feasible to scale up so that laboratories on ground can perform this kind of tests?
Okay, in terms of this equipment, the major issue is the startup cost, because it costs about 9,500 euros, and that's what has a range of products. But training people a 1 week training for MinLab would be enough, or while for the other ones, it's just a day or 2 days training. So the MinLab can take 1 week for people to be trained and have built the capacity. The challenge is to the MinLab, I think, is slightly expensive because it's 9,500, so you need the whole equipment at a different facility. So far as a country, I think we have a few of them who are running. The cheapest one was the pad, because the pad we use much of the water and the papers. Or while for the pill scan, I think it will take time because the equipment is still in development. In terms of capacity building, during the implementation of the study, I've been able to have 2 extra people whom we have been 2 to 3 extra people, not 2 but 3. 2 of them within the department and 1 of them a government employed internee to understudy us. So I've been able to build capacity on those 3 people. Going for the future, I think we will hope that we will be expanding the group as people are now interested, and we will continue with other medications and thereof.
Thank you. I'm glad to hear that the support has not only helped you doing a specific research project, but is allowing you to build capacity in your own group so that you can also find support for future projects, work with collaborating with those colleagues and continue the work in this area, which is so important. Now we are really over time, and I'm apologizing for that. There was a very interesting question posed a while ago on the chat. Someone was asking to everybody, how do you think being part of CARTA has influenced your research? Now, I know beyond the panelists, there are many CARTA fellows who have come as attendees, and I want to ask you to write down on the chat your own response to that question. How do you think being part of CARTA has influenced your research? And with that, I'm going to thank everybody who has participated in the conference, all the fellows and graduates who responded to the call for abstracts and have been working with us to record those presentations when we had to change to virtual, submit the abstracts. The conference will follow up to publish a book of abstracts soon, hopefully in a week or 2. We want to have it ready before the end of the year to celebrate that those 10 years of CARTA with a big scientific event like this and the publication of the proceedings. Thanks everybody who has attended, everybody who has taken the time to join in one session, the 2 sessions. I hope you've enjoyed at least half as much as I enjoyed. And we hope to see you in future CARTA events. Please send us your ideas, your suggestions on how to do things better, and keep collaborating with us. Reach out to our researchers whenever you want to implement a research project that could benefit from their expertise. And we hope to see you soon in future CARTA events. Thank you, everybody.